Pain Management and Narcotic Prescribing with your host, Leslie. I'm kind of terrible at technology, so apologies if I screw any of this up. Anyways, post-op pain management in surgical patient is an art form in itself, and you'll learn a lot of it on the fly. But this is just some generalized guidelines to help you in your decision making. Obviously, if you have any questions, ask your senior. That's what we're here for. But things to consider when you are prescribing pain medications is the extent of injury. So, is this a patient who just had like a lipoma removed or an abscess drained and shouldn't really need that much in terms of pain meds? Or is this somebody who has a big laparotomy down their midline, a polytrauma with all their long bones broken? So, it's a spectrum. Just kind of know where the patient falls on that. Be aware of if the patient is on home narcotics because they're going to have a tolerance. We generally, look at what they take at home and then add to it, make sure they have adequate coverage. Somebody who takes Perk 10s at home every 4 hours is going to have a much higher tolerance than grandma who doesn't like taking Tylenol because she thinks it's addictive. A lot of our patients have a history of heroin use, so they are going to have a tolerance to narcotic medications. A lot of them will come in on medications to help them with their addiction, like Suboxone, Naloxone, or Methadone. Patients on methadone, that's an opioid in itself, so you generally just prescribe the narcotic on top of the methadone. Suboxone or naloxone will block the effects of a narcotic, so you have to wait until they're out of their system. And you're going to have issues dealing with pain meds or pain control in patients who come in on these medications acutely and need surgery. Patient age, size, and comorbidity should also be on your radar. Again, 40-kilogram little old lady is going to have different needs than a 300-pound, 30-year-old robust guy. So know who the patient is. Comorbidities, like if they already have a tenuous respiratory status, you really don't want to zonk them with a bunch of narcotics because they'll depress their respiratory drive and all of a sudden they're not breathing, which is an issue. Multimodal therapy. Sorry, the title didn't print up there, but it's the way of the future. Everything is moving towards this direction. There's a lot of government stress to cut down on the amount of opioids that prescribers provide, and rightfully so. But other means of pain control that should be your first consideration, even before you start thinking narcotics, is can I maybe give this patient an NSAID? So one we commonly use is ibuprofen. This is available orally or IV, called Ketorolac. Oral dosing is 600 milligrams 3 times a day with meals. Caution, do not give this to a bariatric patient. They're at risk for marginal ulcers. There's another podcast about that. Do not give this to patients in renal failure because, again, it's hard on the kidneys. There's been a movement to avoid NSAIDs in patients with fresh anastomoses because it might increase the risk of an anastomotic leak or complication. But if somebody's here on your trauma service with some broken bones, things like that, ibuprofen is a good use or a good option. Toradol is a great drug. This is available IV, and the dosing, it'll pop up in the chart as 15 or 30, but Dr. Chambers sent out a study showing that 10 milligrams provides equal relief and patient satisfaction and is a lower dose. It's dosed every 24 hours. You have to reorder it just because it can be hard on the kidneys. It kind of forces you to check out, yep, their creatinine is okay. It's okay to redose it, but a great drug. Non-invasive things like heat and ice are excellent options. The beds here are notorious for being hard on people's backs. Sometimes all you have to order is a K-pad, that's a heating pad. Whenever the patient wants it, it's not going to kill them. Some people like heat, some people like ice, whatever they want, doesn't matter. Acetaminophen, a great drug. This is available orally or rectally or IV. The IV stuff is a little more expensive, so you have to call pharmacy and ask them for a 24-hour dosing. If your patient's tolerating a diet at all, they're going to say, nah, give them the oral stuff. And you can give a maximum dose of 4 grams a day. So if you order 650 milligrams every 4 hours, that equates to about 3,900 milligrams. Again, every medication we give should be custom to your patient. So if a patient just had a big liver resection or has a history of cirrhosis, don't be giving them acetaminophen because it's hepatotoxic. Gabapentin is a great medication for neuropathic pains. This is available orally. A nice low dose is 100 milligrams 3 times a day. That's a very low dose. And if the patient's on this for more than a month, then they have to taper off of it, but generally not an issue in our population. Lidoderm patches, a topical analgesic, go crazy. They're expensive, so ordering them in the outpatient setting is an issue, but while they're here, slap them on. If you have to use narcotics, start small and titrate up. It's a lot easier to give more medications, kind of a bigger issue once you've given too much. IV stuff has a faster onset, but also has a faster off switch. So this causes a higher addictive potential. Some common medications we use are morphine and Dilaudid. We rarely prescribe fentanyl. Sometimes anesthesia will post-op. Once in a while, people will say they're allergic to morphine and Dilaudid. That should be a red flag. Fentanyl kind of gives I guess, a big high. So, and it's expensive, so we rarely use it. Morphine is nice because you can dilute it and to give 1 milligram to a little old lady. But 2 milligrams of morphine is about equal to 2.5 of Dilaudid. And probably the most common medication I order is half a milligram of Dilaudid every 3 to 4 hours for severe pain. Once the patient is generally tolerating a diet or immediately out of the post-op period, we'll start them on an oral medication. This has a better baseline coverage, and then usually we leave the IV stuff for breakthrough pain. Any of these medications listed here, they're listed in order of kind of strength. So tramadol being the weakest, OxyContin being the big guns. The dosages I have listed here, like you can give 1 to 2 of those tabs. And again, these are longer lasting, so give good baseline coverage. Something you have to be aware of, and you'll figure this out as you progress through the years. This is not something you can really memorize coming in, but every one of our staff has a personal preference. Dr. Aguila does not like his patients who are NPO to be on oral pain meds, whereas, Dr. Miller or whoever really doesn't care. So just kind of ask them, hey, are you okay if I start them on oral narcotics, or do you want to stick with IV? And they'll let you know. Something else to be aware of is what does this patient have as far as access to their enteric system. If they have a PEG tube or a J tube, you do not want to clog that. That is bad news. So you might use like the oxycodone elixir because you can fit it through a J tube. Be aware that the Norco and the Percocet also have Tylenol in them. That's the 5-325. The 5 stands for the amount, like Norco, 5 milligrams of hydrocodone, 325 milligrams of acetaminophen. And you can dose these every 4 to 6 hours. The OxyContin continued release, that's given twice a day. Sometimes if a patient's got a multitude of injuries, we might do the OxyContin continued release, and then on top of that, give them some Percocet, 5, 325, 1 to 2 tabs every 4 hours. And on top of that, maybe even some Dilaudid. And then we do that for like polytraumas, root fractures, stuff like that. PCAs, we use quite a bit as well, mostly for our patients who have big laparotomies down the midline. 3 components to it, so the demand dose, the lockout interval, and the 4-hour limit. With a morphine PCA, I've maybe prescribed 1 or 2 of these, not something we commonly use, but the demand dose is 1 milligram, so every time they push the button, they get a milligram of Dilaudid. The lockout interval is 6 minutes. They can only push it every 6 minutes. And the 4-hour limit is 40 milligrams, and kind of how that calculates out. So if you get 1 milligram every 6 minutes, that's up to 10 times an hour. So that's 10 milligrams per hour times 4 hours is 40 milligrams that you can get in 4 hours. With the Dilaudid PCA, common settings we use are 0.2 for the demand dose, 6 minutes for the lockout time, and 6 milligrams total every 4 hours. If you do the math on this one, the 4-hour limit should actually be 8 milligrams, but that's not a small amount, so we just kind of cut it back to 6. Here's the order set. I kind of botched this. One of the red boxes is in the wrong place. I apologize. But so you click on morphine additive. That's the part in blue. And then the PCA demand dose is at 1 milligram. The lockout interval, that's where the other red box should be, is 6 minutes. And then the 4-hour limit is 40. On the Dilaudid PCA, again, demand dose 0.2, lockout 6 minutes with a 4-hour limit of 6. In patients who come in on chronic narcotics or are having just a really hard time with pain control, you can also add a continuous rate. So 0.1 is usually what we'll do, and that means they'll get 0.1 milligrams of Dilaudid every hour in addition to the demand dose. Let's say a nurse calls you at 3 in the morning saying, so I misread the 0.5 milligrams and accidentally gave your 95-year-old patient, Miss Jones, 5 milligrams of Dilaudid, and now she's not breathing. This shouldn't happen because the Pyxis has the medicine dispensal system has a safety on it that would prevent that. But you will encounter patients who got too much narcotics and they sternal rub them, they're not waking up, shallow breathing. So what you do is you provide respiratory support. Maybe you have to intubate this patient to protect their airway, sit them up, bag mask them, but make sure somebody's running to grab the Narcan, 0.4 milligrams. Give that every couple minutes or so until they wake up, and it works pretty well. So that's kind of inpatient pain management. As far as prescribing medications, so obviously got to send these patients home with pain meds too. The government has recently set these pretty steadfast rules that limits the amount of narcotics we can prescribe. The rules are you cannot prescribe extended release meds for acute pain ever. So no OxyContin, no morphine continued release. You must document in the patient's medical record that you discuss the risks, benefits, and alternatives to opioid medications. You must have a parent's written consent for minors, usually not an issue for us because a lot of them go to Nationwide. You can only prescribe for 7 days or 5 days for minors. And if the patient needs more pain meds after that, they need to see you in office. You need to reevaluate them and write documentation in their chart saying, yeah, I saw them. Yeah, they need more pain meds. Yeah, at that point, you can write for another 7 days and then repeat the process. And scripts must have an ICD-10 code. That's like a diagnostic code. I'll show you a slide on that in a bit. Exceptions to this rule are patients in hospice, palliative care who have cancer, that's a big chunk of our patients, terminal conditions, or are on addiction medications. So as far as the ICD-10 code goes, your seniors will show you how to write discharge scripts, but you click on the diagnosis tab and then you add a diagnosis and click that checkbox, and that associates the diagnosis with the pain med, and it'll print it on the script for you, and that'll keep you out of trouble. Pharmacies will call if you don't put that on there and demand it, so save yourself the phone call. You can write for a maximum of 30 morphine equivalents per day unless additional documentation is completed. Common scripts, these are things that you should probably type in and save under your medication folders. The most common one that I send people home with by and far is Norco 5325, 1 tab every 4 hours for 7 days for a total of 42 tabs. And again, we'll go through with you how to write scripts, where all this information goes. If you're writing for Percocet, 1 tab every 6 for a total of 28 tabs, or Perc 10s, 1 tab every 10 hours for a total of 14 tabs, and Tramadol you can see there as well. So these are good to save because you will be using these a bunch. That's all I have as far as post-op pain management and script writing. There's a lot to it. Like I said, it's kind of an art form. Got to know your audience, know your patient, know your options, but you'll figure it out pretty quick because it's something that we deal with on a very common basis. So any questions, ask your seniors. Otherwise, welcome to the program. We're very glad to have you.